Good morning and welcome to class. So my name is Eunice. I will be your instructor today, and you all are here for the IV therapy course, so welcome. 30 hours, you did most of it online, and now we get to just do the hands-on. When I first started IVs, umpteen years ago, I've been a nurse now for 27 years, I was afraid to start an IV because I didn't want to cause pain to my patients. Well, then I would always rely on the charge nurse. And I'd be like, hey, her name's Rose, love Rose. Rose, would you start this IV? And I built this patient all day. I built a rapport with this patient. And then guess what? Whenever Rose pulls out the catheter, or, as far as pulling out his packaging, about to start the IV, the patient still said the same thing that I didn't want the patient to say, ouch. And I'm like, so I bothered the nurse, the charge nurse, to start an IV, and the patient, whether it was real pain or anticipatory pain, said ouch anyway. But how long do they say ouch for? A few seconds, and then it's in. And so I felt that if I was going to be a strong nurse, I needed to go ahead and at least try, okay? Because either she, a person that this patient's never met, is going to inflict this pain, or me, I've been holding your hand, I've been taking you to the bathroom, and I just felt that the patients would feel best if it was me starting the IV. And so I do really want to thank you all for taking the course. The way that I started phlebotomy, way back in the day, it was a local hospital. They had just opened up, and it was one of the biggest hospitals, big and beautiful. That's all I'm gonna say. And the house supervisor, when she met me, I was an agency nurse, and she said, hey, here, all of our nurses have to draw blood. I had never drawn blood before, but I had started IVs. I drove all the way out there, so I wasn't going home. So you know what I said? I can draw blood. And so this is a safe place for you to learn your techniques. And so right now, today's class is IV therapy. I promise if you can start an IV, you can actually do venipuncture. You can also draw blood. It's just more to it because then you have to learn the order of draw. But in your actual online modules, there should have been information about that. So I said all that to say this. Welcome. It's okay to make a mistake here. Our mannequins will live if you make a mistake. Unfortunately, what's happening now, and I like to talk about that CNA who transported a patient, Hoyer lift, patient fell, patient ended up sustaining a head injury. She's in jail. Mm-hmm. So back when I made a mistake that caused the hospital to change the way that they did things, and I'll tell you about that shortly, I didn't go to jail. The police were not involved. Now you all, if you make a mistake with IVs, with medications, it's not just you fighting for your nursing license, it's you fighting for your freedom. And so everything we're doing today is with patient safety in mind. So what mistake did I make, you all? Mm-hmm. Heparin and lidocaine, exact same concentrations, red writing on the bag. Because I worked on a telemetry unit, this patient had both because he was having VTAC, but he also, because of the irregularity, he needed to be on heparin. And so I hung a lidocaine, and we're still getting PTs and PTTs drawn, and he's never getting therapeutic. Almost a day and a half later, and this is back when we were doing 8-hour shifts. So that means that 3 nurses, me unexperienced, and 2 experienced nurses had followed behind me. No one checked the bag because it looked like heparin. So in order for them to fire me, they would have had to fire the 2 nurses who came behind me, who also didn't catch the mistake. And because of that, they changed the bags. Now, even though, because this patient has all this, I didn't mistakenly pull anything out because it's actually on his profile. I opened it up. Hey, I can give it to him, but I gave it to him for the wrong indication. And so this patient, he wasn't harmed. His arm may have been numb. What was the outcome? He ended up being in the hospital longer because he wasn't therapeutic. Okay, now let that would have happened today. Y'all already want to write me up. I see you all. So I want you to think about that when you're starting your IVs, when you're hanging these medications. And I'll go around, we'll do a round robin so I can find out where you are within your nursing practice. But we have different levels. Sometimes we have doctors in the class. We have our RNs, we have our LPNs, and we even have new nursing students. So we just want to make sure that you're safe, that you go out and you practice. And as we go through, we'll talk about some cases in which nurses did make mistakes. And so we'll start with you. Just give your first name and tell us a little bit about you. Why are you taking the class?
Okay. My name's Shamaria, but you can call me Shay for short. I'm taking this class because my other class had canceled on me. So I'm like, oh my gosh, I gotta do this now. And I'm an LPN. Yeah.
And new grad?
Yes, ma'am.
Congratulations. All right, and so next,
Suzanne.
Suzanne, let me write, because I have to write her name is Shay. Let me write this down, okay? All right, and so go ahead, Suzanne.
I've also been a nurse for 27 years. Graduated 98?
Yes, well, yeah, we're young.
Yeah. I'm re-entering though. I had retired 6 years ago, 5-6 years ago. And I feel like this is my responsibility to come back and refresh my skills because I started in ICU, left 12 years
Understood.
after that, and then went to private duty. It's been a long time since I started an IV.
Well, we are happy to have you, and I know whatever hospital system, if you decide to go back into a hospital, they're gonna love having your experience, even though there was a lapse, so you haven't, worked with that many patients in a while,
Yeah.
but that experience, that knowledge, it doesn't leave, so welcome back.
Thank you.
All right, next.
I'm Allison. I'm an LPN. I've been doing actually ultrasound for a while, and then before that I owned a restaurant, so I kind of stepped out of nursing for quite a while. And so now my job where I'm doing ultrasound is like, hey, we want you to come and do more nursing stuff, and so I'm going to be starting IVs and things like that again. So
That's wonderful.
it's been quite a few years, and so I want to make sure I refresh my skills.
Perfect. I love it. And so, as you all can see with nursing, there's so many things we can do. And I'm now part of that sandwich generation where I'm taking care of someone who's younger than me, someone who's older than me. And I'm like, oh my God, I'm one of those stories we read about in nursing school. Now that's my life. And so I see the transitions. At one point, you can work 12 hours. At some point, you should work 8 hours. Some points, you're like, I can't do nursing at all. And then when life calms down, it's like, okay, well, I can go back and, maybe work a hospital nursing home again. So great points there. Next, please.
Hi, I'm Julia, new grad LPN. So just job requirements, good to know. It's something good to, experience.
Wonderful, wonderful. And so for Shay and Julia,
Yes.
what's the next plan? Like so we never let you celebrate where you are. It is like as soon as you get one certification or three, we're like, oh, when you're getting your next one, chop. So not trying to do you like that, but have you thought about your next steps?
I thought about doing the bridge program for RN. They have a good one at FSCJ. I'm just missing 2 prereqs, so.
Take your time.
Yeah.
All right, and what about you, Julia?
I'll be going back in February to Bridge.
Okay, awesome. All right, next, please.
I'm Carol, and I'm a new grad LPN as well. We graduated from the same class,
So proud of
so
y'all.
I'm going back in February as well.
So I love how you all are doing things together. Were you all friends before the program?
No, we met in school.
Yep.
Now watch. 6 years from now, there'll be F and P's. It's like, it's like they did everything together, so that is great to keep motivating each other. And then last but not least,
I'm Carla. I'm LPN in the grad too. And yeah, I'm here. I start my bridge program in January too. Yeah.
awesome. And so are you already working in an environment that's requiring IV therapy?
Yeah, I'm start to work at the home care, and yeah, they asked me for IV therapy.
Okay, wonderful. And I just want to make sure, get my names right. So Suzanne,
Yes.
are you RN or LPN?
RN.
RN, okay. All right, so before we begin, I like to discuss rules. And so something that I'm really going to be adamant about, because you're going to start traveling, you're going to be going to different states, is you have to read the Nurse Practice Act for the state that you're working. And don't let a facility talk you into doing something that you're not supposed to be doing. And so we'll talk about the differences between what an RN can do and an LPN can do. And so we want to start off with the stapled sheet. I think it's on the upper corner of your tables. And so this is chapter 64B9-12, Administration of Intravenous Therapy by Licensed Practical Nurses. I did not download the one for RNs because what an RN can do supersedes what an LPN can do. And so Susan, if you have any questions, we can talk about that separately. So I'm not going to read the subtitles there or the statement of intent and purpose because it's a whole bunch of numbers. Anytime we get to numbers, you can just say that rule, that number, but let's start with definitions. So administration of intravenous therapy, it is the therapeutic infusion and or injection of substances through the venous peripheral system, consisting of activity, which includes observing, initiating, monitoring, discontinuing, maintaining, regulating, adjusting, documenting, planning, intervening, and evaluating. 2, under the direction of a registered nurse, means that the registered nurse has delegated intravenous therapy functions to a qualified licensed practical nurse. The registered nurse does not in all instances have to be on the premises in order for a licensed practical nurse to perform the delegated functions, such as patient's blood pressure is low but you're in a skilled nursing facility and your RN may not be on site. He or she may tell you to, based on the orders from the physician, to start the maintenance fluid, or maybe it's an antibiotic that needs to be hung. Okay, that is something that you can do under the direction of a registered nurse. Next would be direct supervision. Means on the premises and immediately physically available. So let's talk about blood transfusions. Your patient has a blood transfusion going. Can an RN just leave? No. Can you initiate the blood transfusion without the RN? No. So RN has to be there, direct supervision. And number 4, healthcare practitioner means a physician or physician assistants licensed pursuant to chapter 458 or 459 Florida statute, a dentist licensed pursuant to the chapter, or a Florida licensed advanced practice registered nurse. Do you all remember when it was ARNP? I'm like, why do they keep changing everything around? So now it's APRN. But that would be some of the definitions. And now we're going to ask that Shay, would you please read the next section, aspects of intravenous therapy outside the scope of practice of an IV certified LPN?
Okay. Unless under the direct supervision of a registered nurse or healthcare practitioner, as defined in Rule 64B912.002 FAC, an IV certified LPN, who meets the qualifications set forth in Rule.
You can just say the rule.
The rule. Shall not perform the following: initiation of blood and products, initiation of blood products, initiation of administration. Initiation or
You got it, girl.
Administration of cancer chemotherapy, initiation of plasma expanders, initiation or administration of investigational drugs. Although this rule limits the scope of an IV certified LPN practice, it is appropriate for an IV certified LPN to care for patients receiving such therapy.
Perfect. Any questions there? All right, so next one, if I can get you to read, please, Suzanne, if you'll read the rest of this page, starting off with the title.
Okay, authority for the LPN to administer limited forms of intravenous therapy. With the exception of those aspects of intravenous therapy deemed outside the scope of practice of the IV certified licensed practical nurse, one who meets the qualifications set forth in subsection blah, 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 and subject to the approval of the institution at which the LPN is employed, any licensed LPN who meets the competency knowledge requirements of rule below is authorized to administer IV therapy under the direction of a registered nurse or other healthcare practitioner as defined in this rule. Individuals who have completed a board-approved pre-licensure practical nursing education program, professional nursing students who qualify as graduate practical nurses, or licensed practical nurses who have not completed the specific course under this rule may engage in a limited scope of intravenous therapy under the direction of an RN or other healthcare practitioner. This scope includes A, perform calculation and adjust flow rate, B, observe and report subjective and objective signs of adverse reactions to IV administration, C, inspect insertion site, change dressing, and remove intravenous needle or catheter from peripheral veins. D, hanging bags or bottles of operating fluid.
Thank you so much. And then, Allison? Okay, Allison, for the next section, can I get you to read 1 through G?
Competency and knowledge requirements necessary to qualify to LPN to administer IV therapy. The course necessary to qualify a licensed practical nurse or graduate practical nurse to administer IV therapy shall not be less than 30-hour postgraduate level course teaching aspects of IV therapy. The didactic intravenous therapy education must contain the following components: policies and procedures of both the Nurse Practice Act and the employing agency in regard to intravenous therapy. This includes legalities of both the licensed practical nurse role and the administration of safe care. Principles of charting are also included. Psychological preparation and support for the patient receiving IV therapy, as well as appropriate family members, significant others. Site and function of the peripheral veins used for venipuncture. Procedure for venipuncture, including physical and psychological preparation, site selection, skin preparation, palpation of veins, and collection of equipment. Relationship between intravenous therapy and the body's homeostatic and regulatory functions, with attention to the clinical manifestations of fluid and electrolyte imbalance. Signs and symptoms of local and systemic complications in the delivery of fluids and medications, and the preventative and treatment measures for those complications. Identification of various types of equipment used in administering intravenous therapy with the content related to criteria for use of each and means of troubleshooting for malfunction.
Thank you, thank you, thank you. So Julia, you now have H through O.
Okay. Formulas used to calculate fluid and drug administration rate. Methods of administering drugs intravenously and advantages and disadvantages of each. Principles of compatibility and incompatibility of drugs and solutions. Nursing management of the patient receiving drug therapy, including principles of chemotherapy, protocols, actions, and side effects. Nursing management of the patient receiving blood and blood components, following institutional protocol, including indications and contraindications for use. Identification of adverse reaction. Nursing management of the patient receiving parenteral nutrition, including principles of metabolism, potential complications, and physical and psychological measures to ensure the desired therapeutic effect. Principles of infection control in IV therapy, including aseptic technique and prevention and treatment of iatrogenic infection.
Yes.
And then nursing management of special IV therapy procedures that are commonly used in the clinical setting, such as a heparin lock, central lines, and arterial lines.
Perfect. And so Carol, can I get you to read P through 3 and we'll stop at A. It'll make sense in a moment.
A glossary of common terminology pertinent to IV fluid therapy. Performance checklist by which to evaluate clinical application of knowledge and skills. Clinical competence. This course must be followed by supervised clinical practice in intravenous therapy to demonstrate clinical competence. Verification of clinical competence shall be the responsibility of each institution employing a licensed practical nurse based on institutional protocol. Such verification of a licensed registered nurse. And then you want me to read 3?
Yes, ma'am.
Central venous lines, CVL, and peripherally inserted central catheter lines. The board recognizes that through appropriate education and training, a licensed practical nurse is capable of performing intravenous therapy via central and PICC lines under the direction of a registered nurse or other healthcare practitioner as defined in subsection. Appropriate education and training requires a minimum of 4 hours of instruction. The requisite 4 hours of instruction may be included as part of the 30-hour required for IV therapy education specified in subsection 4 of this rule. The education and training required in this subsection shall include at a minimum didactic and clinical practical instruction in the following areas.
Thank you so much. And then Carla, can I get you to read the rest of this page?
Central venous anatomy and physiology, CVL and PICC side assignments, CVL and PICC dressing and cap changes, CVL and PICC flushing, CVL and PICC medication and fluid administration, CVL and PICC blood drawing, and CVL and PICC complication and remedial measures. Upon completion of the intravenous therapy training via central and PICC lines, the LPN shall be assessed on both theoretical and knowledge and practice, as well as clinical practice and competence. The clinical practice assignment must be witnessed by RRN, who shall file a prophecy statement regarding the LPN's ability to perform IV therapy via central lines. The prophecy statement shall be kept in the licensed practice nurse personal file.
Perfect. And then number 4, providers. The LPN/IV education must be sponsored by a provider of continuing education courses approved by the board pursuant to the rule. To be qualified to teach any such course, the instructor must be a currently licensed registered nurse in good standing in the state, have teaching experience, and have professional nursing knowledge, including IV therapy. The provider will be responsible for issuing a certificate verifying completion of the requisite number of hours and course content. And so, you all, today, I think we normally get out between 3 and 4. Towards the end of the day, when we're doing our PICC and our CVL training, that's when I will open up your final examination. Once I open up your final examination, you're welcome to start. It'll time out in 2 hours. But we only have one of the chest mannequins that allow you to draw blood from a central line, so it doesn't make sense for you just to be waiting. So you can start taking your test. Once you pass your examination, because you're going to pass, it is 100 questions. I've not had a student fail yet, okay? Once you pass, you just come right over here to me and I will issue your certificate that is valid for 2 years. Now, your employer may not require, especially if you're going to be an RN, you don't have to come back. But if you're still an LPN in 2 years, well, then you're going to have to come back and recertify. And unfortunately, there is no shorter course. It's the same course all over again. So let's say you make a mistake on the floor. They don't care, like they do a BLS, like they'll take you off the calendar. You can't work on the schedule if your BLS certification expires because they monitor that. They're not really monitoring your IV therapy certification. So if something were to happen and you made a mistake, that's when they're going to ask you for your IV therapy certificate. And then if it's expired, well, we know what's going to happen. You're going to be fighting for your own license because you were not current. So just keep that in mind. Certificates will be printed, given to you. Take a copy, go ahead and screenshot it, send it to yourself, because if you lose your certificate, I charge $25 to replace them. Yes, I do. That is my son's fund money, because I need for you all to not be calling me every 6 months asking me for a certificate. So I have literally had a student who has called me twice a year for 3 years for us to send her, not for this course, another course, an electronic copy of a certificate there. She just saved it in her email. But you know, hey, we can't help everybody. You know, we try our best. So your course today also includes PICC and CVL, so you get practice on that too. I like to start off now with a review. Our first break will be about maybe 30-45 minutes. So we talked about direct supervision, and we understand what the Nurse Practice Act is, and that whatever state you're going into, and this isn't anything that's on your in your ebook, it's just us going through to make sure that you actually paid attention to the modules that were in the online course. What are some reasons for IV therapy?
To administer medication, to help with fluid balance.
Perfect. We'll take that. That is great. All right. And so, Julia, what are some of the risks involved? Julia.
risk involved IV therapy?
Mm-hmm.
Like,
So if something goes wrong, what are some of the risks? What's the worst thing that can happen if you start an IV? What's gonna happen to that
I'm
patient?
trying to think of the word. Interstitial, when it goes into the tissue fluid.
Oh, you don't have to use big
Oh.
words here.
Oh.
So what's the other word for that?
If it blows.
It blows?
Yeah.
Okay, all right, so it can blow, and when it blows, what will we see?
What's
that big bruise called?
hematoma.
Hematoma, okay, and so, some other risk involved, let's say you had poor technique, you didn't clean, what's gonna happen?
Infection.
Infection, let's say your patient's on a blood thinner, what's gonna happen?
They're bleeding.
Girl, yes, all of that stuff, yes. So those are some of the risks, and so I think you were trying to, when you said blow, oh my God, now the word is like, escaped me, it's not evisceration. Infiltration, there we go, it's early in the morning. Bloodborne pathogens, I am looking for my roster and I put it down, and that's not good because I don't know everyone's names yet. I know Carol's name, Carol. All right, so Carol, let's talk about bloodborne pathogens. Can you name a few? They may not be in your book. So bloodborne pathogens. What pathogens could you contract if you got stuck with a needle?
What happened if you get
So
stuck?
you were starting the IV, the patient moved, and you had already pierced the patient's skin,
Okay.
and now your finger got pricked.
Oh, okay.
Bloodborne pathogens. And so the way I teach is I need you to pull it forth, because again, when a lawsuit occurs, they're not going to come to me. It's you. So I need to make sure that you understand some of the risk involved whenever you're starting the IV.
HIV, hepatitis, and hepatitis B and C.
Okay. And so for things like that, I need to roll off they have to roll off a little bit quicker because you're a nurse. So we're in the medical field. We talk about bloodborne pathogens. You got to be able to say what they are.
Okay.
Which one has a vaccine?
Hepatitis B.
Yes. And so I'm going to teach you techniques here so that whenever you're starting your IVs, number one, old school, do not take your glove off of your pointy finger so you can palpate. You can palpate before you start. Number two is when you're anchoring a vein, you don't anchor with two fingers. Because if you're anchoring and the patient flinches or you miss, you can stick yourself. So you anchor with one hand. So I'll be teaching you those techniques today. And now I'm back to you, Suzanne. A nurse has stuck herself. What should she do after having a needle stick injury?
Immediately wash with soap and water.
Okay.
Notify the nurse in charge.
There we
The
go.
proper chain of
command. And so, is there a medication that she could get prophylactically if she's thinking that she could could have contracted HIV or AIDS?
yes.
There is. Yes, there is. And so,
Human resources.
yes, human resources, employee health, all of them will get involved. Does the patient have to agree to be tested for bloodborne pathogens, HIV? No. So that's why it's so important for you to protect yourself. And of course, we have our sharps containers. You'll see those in a few moments. Let's go to you, Allison. Tell me the difference between the red bag and the sharps container.
So the sharps container, you would put anything that's sharp, so like IV, like anything with a needle, scalpels, things like that. And then the bag would just be for blood contaminated products.
Perfect,
So like
perfect.
if you got blood on gauze or things.
So nothing sharp going into the bag or, and then we don't want to be putting a whole bunch of gauze in our, it's like, okay, come on, let's figure this out.
Saturated.
Yes. All right, and now as far as your glove size, whenever you're replacing your gloves, especially for our new nurses. So let's say you go in, have you all worked the CNAs? Okay. So you go in and you see that your size glove is missing. I need for you to replace all the gloves. Just be nice to everybody, because there's nothing worse than you're calling a male tech in there for help. And he's like, hey girl, I'm here to help you. And you make him put on small gloves. So just go ahead and restock everybody's gloves. Hand washing, Julia, how many seconds of friction? 20 seconds. And so according to the Infusion Nursing Society, it is not 20 seconds. For IVs, it's 30 seconds. So just keep that in mind in case you see it on your test. All right, and so we do understand that hand sanitizer does not kill all germs. Give us an example, Carol.
C. diff.
Perfect. Sharps container, we talked about the super saturated items that will be going into the red bag. A lot of your needles, I'm going to call them the catheters, you'll see them in a few moments, they have safety mechanisms. So if it has one that has like a little, I'm going to say a device that covers the needle, you're not supposed to use your finger to activate that device. Instead, you would press it against the table. Some of the other ones that we have are auto retract. And so whenever you're going around to all these different facilities, because I know you're going to be making your money, you're going to be at hospital A, hospital B. Every hospital may have a different supplier. So you are responsible for knowing how to use the equipment that's at that hospital. And if you don't know how to do something, Shay, what are you going to do?
Talk to the head nurse in charge.
Yeah, ask questions. Even if, look, I'm not trying to hurt myself. I don't want to hurt this patient. This is my first time seeing this type of angiocath. Will you just tell me how to use it? Let's talk about understanding the gauge size. So the smaller the gauge, the larger the diameter. The smaller the gauge, the larger the diameter. Let me get some needles on the right back. These are different types of your angiocaths or your straight needles. They have different gauges. So this is 18 gauge, this is 20 gauge. I can never remember by color the gauge size. I refuse to remember by color the gauge size. You know what my old butt does? Oh, 18 gauge. I just go ahead and I read. Now, let's talk about hand veins. Whenever you're choosing an IV, you need to be thinking about the indication. And so if you just need to hydrate a patient, right now the order says normal saline at 125 an hour. Why do we start distally first?
Just in case you need to go up.
Yes, because if we miss or if it blows, we don't want to blow the antecubital. What your paramedics do is they start, look, they're like, hey, we're going to start the best. We're out in the field. We're going to start here in the antecubital area. The problem is they then have to, once they're in the hospital, you will have to remove that IV within 24 hours. Because we know what happens in the field. It may not be the cleanest. And if that person gets an infection, we're going to be liable because we know that that IV was put in the back of the ambulance and we didn't take it out. So usually the ones that are in the antecubital are going to be for different indications. And so I'm going to expose my little arm here. All right, so hand vein, 18 or 20 gauge. 20 gauge for a hand. Antecubital. You can probably do, I know, right? Y'all just, she says whatever you want. It's nice and simple. All right, so what would be the indication for an 18 gauge? Blood products, or maybe contrast. If you're working in like sonography or radiography, they're going to need a more secure vein because what's going through it is going to be more caustic. What does that mean? Sticky, irritating. It's going to irritate the vein. And so think about that. A bifurcation is kind of hard to see. A bifurcation is where what happens? So it's like, it's a split. Can you see it back there, Julia? Okay. So whenever someone has a bifurcation, there's usually a valve in the center. And so if you start low, you're either going to go through the vein or it won't advance because the needle's going to hit what? The valve. So if there's a bifurcation, you go above the bifurcation, not beneath it. So everybody look at your own hands. Let's see your bifurcations. All right, and so if you were starting IV, where would you start on that on yourself? And think about the length of this needle, okay? Perfect. Oh, girl.
I know,
Oh.
right?
Beautiful. Very
It's
good.
getting
Yes, let's see it over there, Julia. Yes. Let me see yours. Man, y'all have some good veins. You know, I'm happy now. Perfect. Yes, we have to go above. All right. What are the differences? And I'll call this a straight needle, an angiocath versus a butterfly, because we don't have butterflies here. So what's the difference? How does the patient feel about seeing a cute little butterfly versus this? Okay, so it's usually going to be smaller. When I say smaller, the diameter is smaller, the length is smaller. Who would be the best person to have a butterfly needle? Pediatrics, and who else? Elderly. So you've got to start making some considerations for your different patient types. What do we mean by rolling vein?
When it's moving.
It moves. How do you prevent it from moving? You gotta anchor it. You gotta anchor it. Don't anchor it. You have to anchor it. You have to stabilize it. And so you'll be practicing with these shortly, but I just want to make sure that you understood there are different sizes, and the different sizes have, different, just think of the clinical reasons. Don't be starting an 18 gauge in a patient if they don't need blood. That's an income that I know you want to, like, oh, look at that big, beautiful vein. No, the patient did not require it. You have a very dehydrated elderly patient who requires blood. You cannot get 18 gauge in them because of what reason? They're dehydrated. So what do you think the best course of action would be?
Give them fluid first and then.
Yeah, so start off with a smaller gauge. Start off with your 22 gauge. Hydrate them, because obviously if they're dehydrated, they're going to have water for saline. So hydrate them, and then once they're more hemodynamically stable, once they have more fluid within their body, that's when you can start your 18 gauge. So sometimes in order to get them blood, they may have to get stuck twice. Once with the smaller IV, so that we can actually hydrate them, so we can now have enough volume within the vein in order to start the larger IV. I know, right? It's a whole bunch. Okay, let me go there. We did that. We talked about that. We talked about prep. Who knows about Redonda Vaught? Hope I said her name right. Redonda. Does it ring a bell? So I don't know what state she was in, but she ended up fighting for her nursing license. She killed a patient. She says that according to what's happening at her hospital system, overrides were normal. And so she was trying to get a medication out, and the medication dispense system would not allow her to get the medicine out because it wasn't on that patient's profile. She did whatever she needed to do. She got the medicine out. It was a paralytic. She paralyzed the patient. The patient died. So, what should have been done differently?
She shouldn't have overridden.
She should not have overridden. If you're adamant that that is that patient's medication and you need it, what should you do?
Get a second set of eyes.
Get a second set of eyes. What else should you do?
Call them like the order. Yeah.
So you all in the medication rooms, there's a phone.
Mm-hmm.
A phone that goes to pharmacy. Okay, the doctor's gonna think you're freaking crazy. If it's like, no, I know I ordered XYZ and you're calling me about ABC.
Right.
So it's more than likely you.
Mm-hmm.
So go ahead and call the pharmacist, and then the pharmacy be like, no, that's not on the profile. That's when you can call the doctor, okay? But she was supposed to be given something else, and she gave zirconium instead, and she paralyzed him. And that should not have happened. And so she's been fighting for her license. I think they finally, decided that she could not get her license back, but the audacity of her to fight for her license after she did the override that killed the patient. I say if people don't have anything else, they have the audacity, and that's what she has. So my apologies to that family. If you are doing home care and you don't have pharmacy readily available and you have a question about a med, how are you going to get that information? We got to think outside the box. How are we going to get the information? Are you going to go to ChatGPT?
No.
No.
That's
So if you're, I love you. I bet she would. She's going to turn around her drug book. I know her. She's going to have her drug book. For everybody else, you can use an app called Hippocrates. And if you're working for a reputable home care company, should have you are gonna have laptops. So Hippocrates is something that a lot of schools use. What is the difference between the intranet and the internet?
The internet is like social networking and the internet is like your more.
Not quite, not quite. So when you say social, this one's not for social.
Okay.
This one prevents social.
Okay, I have them backwards.
So what is the intranet, everybody? Company approved.
Okay.
So this is why when you go to your job and you're like, why can't I get on TikTok? Because they don't have you connected to the internet, they have you connected to their intranet. And usually their intranet has their approved medication, their approved resources. So if you're in home care, I need for you to be thinking outside the box, because if you have a question, you can't really call a pharmacy right then. And God forbid if you call one of the big box pharmacies, if they answer. So you keep those leaflets, keep all the patient information, because your patient may be asking you a question. It could be a new medication order, and I need for you to know what to do, what the side effects are. All right, so that's the main thing. So we're not using ChatGPT. We're not using anything that is not approved. Don't use anything that's going to get you sued or your patient injured. That's my TED Talk.
And also, if you're doing home health, you can also call the pharmacy that medication was from.
Yeah, some of them are like shipped in though. You know, like they're like mail services or delivery services. So, you know, again, this one's like reputable home care company who understands they're not leaving you out there by yourself. Hopefully they're gonna have some type of resources for you. Because I would hate to walk into a house and this patient has, you know, some new antibiotic that I've never heard of. And I'm looking at them like, wow, this is new. Let me go to the bathroom. All right, so let's talk about vascularization. What is the difference between an artery and a vein as far as you palpating?
Arteries and a pulse.
Our arteries are going to pulse, and they're deeper. Okay, and your veins are more superficial. They should not pulse. How should they feel? Okay, so nice and bouncy, spongy. How do you know someone's a drug user from just palpating? What are you going to feel? Because that's important. You got to start. You're doing your side assessment. You're like, oh.
Hard and rigid.
It's hard. Scar tissue. They've overutilized it. They've put caustic drugs in their veins. So that would be something that you won't use that vein. You may have to go above it if there is anything that you can utilize above it. Tell me some other contraindications where you couldn't use an extremity for IV. Dialysis. There's shunt. What else? What is it?
Therapy.
Chemotherapy. Something else, you all.
Mastectomy.
Mastectomy, yes. And you just can't look at someone and determine if they had a mastectomy, because if their cancer's been in remission for a number of years, they will go back and have reconstructive surgery. So it's never just looking at someone. Is it okay if I start an IV on this one? And if they can't give you the information, make sure you're looking at the what?
Their health history.
Yes, their H&P is going to give you some information, and then you may have to get a doctor's order to use that, if that's the only vein accessible. Burns, scars, if it doesn't look right, don't start IV. So your patient has an AV fistula in their left forearm. The only accessible site would be for you need to give blood or something. It is the right antecubital. Where does your CNA take the blood pressure? Because y'all have to tell them. They won't know.
The right arm.
Where on the right arm?
Before or after the IV started?
The IV's going, girl.
Okay.
And we have to do vital signs because they're getting blood. So you're gonna put the blood pressure cuff above or below? How are they gonna know it if you don't tell them that? Okay, or worst case scenario, they can use a leg. Now, with leg blood pressure's done on legs. I've never known if the reading was right. As long as I got a reading, I was okay. But then you put it on the calf. I see your facial expression, girl. What's going on?
No, I'm curious about the where that the cuff at the leg.
The calf. Touch your calf. CALF. Touch your calf. That's your ankle.
Here, like this.
Up higher, calf.
Like
Yes. Yes. Where the big muscle is, you put it there. And then just go online and research it, but most of us are just going to use the forearm, and they even have automated cuffs that would go on the forearm. Your facility would not have it, but for home care, they have the like wrist cuffs, etc. But if you cannot, because if they put the IV cuff above your working IV site, when that cuff squeezes, what's going to happen to your IV? It's going to pop out. So we don't want that happening. Now let's talk about this IV that's in the hand that has normal saline with KCl infusing. Same patient who has a dialysis shunt on their left, so you cannot use the left. You have infusion with normal saline and potassium, and now lab comes and says, hey, I need to draw a BMP and a CBC. What are your thoughts?
You have to
Stop
wait.
the infusion.
You have to, and so we don't want to use the word stop because that would require a physician's order. What are we going to say instead?
We're gonna clamp.
We're going to pause the infusion, and so that requires you to work as part of a team. That lab tech came to tell you that for a reason, because if you allow him or her to draw the blood and she's drawing a BMP, but there's potassium and saline infusing, what labs are going to be skewed? She said all of them.
Well, I mean,
Not just potassium, what else?
Sodium.
Sodium, it could be skewed. Let's talk about a patient who's receiving heparin. And we only have that one arm. That means that the levels are going to be skewed also. So do them a favor. When they come to you and say, would you pause it? Go ahead and pause it. It's not like you're doing it for 5 minutes. Just enough for whatever blood to start circulating so they can get their lab specimen. What questions do you have on that? All right, we'll keep on going. Controlling bleeding. We talked about arteries and veins. Now we've performed our, we've removed the catheter. So now it's time to discontinue the IV. How long do we apply pressure?
30 seconds.
30 seconds? What do you all say?
a few minutes.
A few minutes? Anyone else?
Until it stops bleeding.
Girl, that's the answer. Because we have these patients who are on, the person who had heparin, when you take out their IV, guess what?
It's gonna bleed.
It's gonna bleed. Okay, and so how do you know if your patient is at risk of bleeding? I can look at somebody and be like, oh, they're a bleeder. So what do you see on their arms?
Bruising.
Bruises, petechiae, hematomas. What else might you see? How do you know if a person's fallen before and they have frail skin? What would you usually see on them? The skin tears, the flaps. It's like, okay, we try to pull it back over. And so when I see that and I'm walking to the room, that means I'm not using Band-Aids. Because if I use a Band-Aid, what's going to happen? So what are we going to use instead of a Band-Aid? Gauze and something else. It sticks to itself. The Coban. I don't have it over here, but yes. So it's like you have to be on it. You are trying to protect your patient. Even a Band-Aid can tear off their skin. So if you already see all this going on, we don't put Band-Aids on bruised skin because it's going to make it worse. Okay, we talked about starting distally. We're going to go through our veins. Why don't we start, unless you really dislike your patient? Why do we go for the back of the hand or the antecubital versus the forearm?
It's more sensitive.
It's more sensitive. So yes, we can, look, I have veins there, but I'm gonna need for you to love me enough to start somewhere else. Versus starting, on the, so we don't usually start on the forearm. We're gonna start distally and then probably work our way up. I was gonna say something about the forearm and I forgot that fast. Jesus, my brain today. Let's talk about some terms that describe venipuncture and IVs. What does patent mean?
Open.
She said patent. All right, so it's open. How do you determine patency?
Flushing it.
Flushing it. How frequently do we flush? Think about your MAR. Have you seen the medication administration record? So usually they're going to say at least once per shift if something's not infusing. What does KVO stand for?
Keep it open.
What rate would you normally set your pump? 10 to 20, somewhere up in there. And usually your facilities will have their set KVO rate, okay? Extra I cannot pronounce that word. I say a lot of words correctly. That's the one that I do not say correctly. What does that mean?
Extravasation.
That's the word. What does it mean, you all?
When like a vesicant medication, something very caustic, infiltrates into the surrounding tissues of an IV and then potentially becomes necrotic.
Yes. And so depending on what facility you're at, they could say cold therapy, warm therapy. Immediately you're going to do what to the IV? Stop it.
One online, it had two different things. So one, it said stop it, like pause it, but don't take it out because you might have to aspirate, like to, or give an antidote.
So I want you to go by your facility policies,
Okay.
because I try to like have all this general information, but if that's the case, just pause it, talk to your charge nurse, talk to the doctor, and then if you need to take it out, you can, and try to aspirate.
What about test-wise?
Test-wise, it's not on there.
Okay.
Yeah.
It was on the practice test one, and so I went back and forth, and I'm like,
That question's not on there. It's
Okay.
like, all right, so
Thank you.
you're very welcome. If you're working with infants and toddlers, let's say you're a pediatric nurse, I'm gonna need for you to learn how to start doing what type of IVs? Where do their IVs go? Is it always in their arm?
On their hand.
Yes. I can't teach you that. Sorry. That's another course for another day. I'm sure those hospital systems, they're going to provide you with that education if they're requiring that as part of your job. What do you need in order to start an IV in someone's foot? An adult.
An order.
An order. So that means that kind of like for intraosseous, if we can't get an IV in an emergency, we can do IO. Look, if PICC line department's full, the interventionist can't come and do a central line right now, but I see a vein in this person's foot, I gotta talk to the doctor about doing that first. Should this be a person who's up moving around? No, they're gonna be bed bound. That was gonna be my question, even if they are ambulatory. Once you put the IV in the foot, they're gonna have to be in the bed. Tourniquets, how far above the insertion site do you want your tourniquet? 2 to 3 inches, perfect. Do you put a tourniquet on a joint? No. We're almost done with our review. Don't look at this big packet. We're almost done. All right, so if a vein blows, what do we do? The vein is blowing. What do we do?
Take the needle out.
Take the needle out and do what?
Cover it with gauze.
And so direct pressure, everybody on your own hand, show me what direct pressure looks like. Clamp. Direct pressure. So nothing like this. You need to actually try to hold that in. And then after that, you put your gauze on. And so let's say 10 minutes later, you're like, all right, let me just take this gauze off so I can see. No. Keep the gauze on. And you can now wrap it with Curlix or something, okay? So we don't want you, once you have controlled the bleeding, to be trying to remove the gauze, because what might you remove also?
The clot.
The clot. Are y'all learning some stuff? I know you know it. We just got to bring it back to your memory. Jeez, are we almost done? No, we're not. I have medical, I have a little calculation. Do not overthink this. Do not overthink this. Do not overthink this. All right, so your order is to give ampicillin 250 milligrams in 100 mLs of normal saline over 1 hour. What is the rate in mLs over an hour? Do not overthink it. Do not overthink it. Do not overthink it. I heard 60, I heard 100, so you all write it down. Write it down. All right, everybody has something written down? Let me see yours. Okay, let me see yours. Okay, let me see yours. Okay. Let me see yours. Okay, let me see yours. Okay, let me see yours. Awesome. Don't make this hard, you all. There should be no reason for an antibiotic to be infusing over 2 hours. If an antibiotic is infusing over 2 hours, it's more than likely vancomycin. So all we had to do is, doctor wants that bag infused in 1 hour. So we need to set our pump at 100. For a lot of your facilities, especially if you're in a nursing home, you may not have pumps. If you're in the ER and there are more critical patients have pumps, they have devices called a dial-a-flow. And so a dial-a-flow is you connect this to the end of your primary tubing. You connect it to the primary. It has to be primed also. So another term, what do we mean by priming tubing?
Getting the air out.
Getting the air out. If we don't get the air out, the patient may get a what? If you suspect the air embolism, what position do you put them in? I love that. Yes. All right, so we're going to circulate this. What you do is once you know your rate, you turn the dial so that it would be at the adequate rate. Now, all your facilities are going to have IV pumps. If you're in the hospital, yes, they have IV pumps. But today you're at Nurse Eunice's nursing home. Okay, skilled nursing facility.
I've never seen one like that.
Yeah.
I haven't either.
You know, like when my mom was in the hospital, little bay that she was in, they didn't have IV pump in there. She just needed fluid, she was dehydrated. So they literally just had her on the dial-a-flow.
Is there some different, like, things that you would think that would be suitable for?
Anything that needs to be titrated, so like cardiac medicine. So when you
Okay.
think of a dial-a-flow, just literally think of simple antibiotic or maintenance fluids. If it's something that has potassium, I would hope they would not be using a dial-a-flow. If a patient gets too much potassium, what could happen to them? Dysrhythmias and cardiac arrest. Thank you. So that would be a dial-a-flow. I'm going to pass around some documents. Let me get the other two. Would you please pass them down? And I'll get these other two over here. So during your test, you are allowed to utilize your notes. How many more do we need? Just two? One. And so somehow you all have notes that have formulas on them. I just don't know how they popped up, but there you go. You have notes that have formulas. And so that should help you when you take your test. Because in the real world, if I can't do a calculation, I'm going to look up my resources. I'm going to go to my charge nurse. And fortunately, we have IV pumps because we have electricity. Think about what happened during Hurricane Katrina. There were nurses who were charged. They were charged with crimes because how are you going to keep someone alive when the power runs out for a prolonged period of time and the backup battery in the IV pump doesn't work? I need for you to know how to do your drips, how to do your calculations, because pharmacy can't help you right then. I know, right? Such scary times, all right? And you know, they're talking about what's the alien that's coming? A13 or something like that. They have that all over the news. There's some type of spacecraft that's coming right now. And I'm like, when the spacecraft gets here, guess what? We're still working 12-hour shifts and we still have to keep our patients safe. How do you determine the drip rate for your IV fluids? Or for your IV tubing, excuse me. Yes, and then as far as the drops per minute,
What's the drip?
Just read it.
Oh, yeah.
so most of us don't care because all we're doing is priming and then the IV pump is going to set the rate. But if you have to do this manually, you need to be looking at your packaging and your packaging will tell you how many drops per ml. How do you know your primary tubing from your secondary tubing? Primary versus secondary. Which one's longer?
Primary.
Primary's longer. So your primary tubing is longer. It has multiple medication ports, or we'll call those like nurse ports. So that means by default, the secondary must be what? Shorter. And guess what it doesn't have?
Medication.
No med ports. And the secondary also comes with the hook. But here's the confusing part. The secondary tubing comes with the hook, but the hook is not for the secondary fluid. It's for the primary. So don't judge me. I'm a nurse, not an artist. Okay. So we know what that is. That's our alien. All right, that's our IV pump. All right, and so this little small bag, 100 mLs, is going to be our ATB, our antibiotic. Now we're going to hook our 1,000 ml bag of normal saline. Think about gravity. What's going to infuse first? The one that's higher or the one that's lower? The one that's higher. So the reason why you hook the saline, I'm always going to say saline, even though you may try to hook something else, you're going to hook the saline so that it infuses after your antibiotic infuses. This is going to make more sense in a few moments. And they connect, and then they go to the happy patient over here, who thanked you every time you went into the room because you're an amazing nurse. Okay.
So you would put the antibiotic higher than the saline.
Yes, antibiotic is always going to be higher. There was something else I want to tell you about that. In our practice today, whenever you are priming your tubing, we rely on a lot of donations. So as you all get further in your nursing career and you have all this expired equipment, you know who to call. Nurse Eunice, come and get this equipment. I will be right there. So with that being said, for us to have enough expired normal saline bags is really hard. So our bags will say D5 normal saline. I need for you, for classroom purposes, to trick your brain. It's normal saline. It's normal saline. Because technically, if you haven't called anyone, your pharmacist, should you be infusing an antibiotic into D5 normal saline? No. So let's talk about those different types of IV fluids. Normal saline is what type of IV fluid? Isotonic. And so it's usually the one that we're going to hang with a secondary medication. So your patient's primary is normal saline with 20 of KCl. And now you get an order for an antibiotic. What do you have to do?
Switch to normal saline.
Normal saline with KCl. You don't want to, if you don't have, if you haven't talked to your pharmacy to make sure they're compatible, you don't want to be running these two together because you could cause a reaction. You could be incompatible. So you're either going to have to start a new IV, which no one really wants to do that. You probably have to get an order from the doctor to pause normal saline with KCl. And then instead of this one being on a secondary, what type of tubing would you use? Primary. So based on what's going on with your patient, because everything can't be connected together, it is okay for you to connect your antibiotic to a primary tubing set. But what's going to happen if you prime the tubing really fast? Where's your antibiotic going to be?
On the floor.
Okay. Well, don't put it on the floor, y'all. The trash can and sink. So that's why we prefer that you, do the connection, that you piggyback it instead. That's a lot of terms that'll make more sense when you all come back from your first break. What is this for? What do you do with it?
Pump it up.
So you prime your primary. If you're using this, more than likely it's an emergency. And in emergency, we're gonna be using normal saline. So you're gonna prime your normal saline. You're gonna put that bag in here, it has a hook. And then you're going to, kind of like a blood pressure cuff, you're going to inflate. This means that it's going to allow that normal saline to go in faster. Sometimes you're going to see pressurized bags, of course, if you're working on a cardiac unit, but you'll also see it in an emergency or if someone has an IO device. I don't teach you IO devices here, but if there's an emergency and we can't get IV, we're going to be doing IO. What does IO stand for? Intraosseous. What questions do you have before you take your first
I
break?
have a question about that bag in particular. I've never seen that. So is that on top of the IV bag itself?
So it slides into the sleeve.
Uh-huh.
So,
What's the purpose of it though?
in order for
Sorry,
you
it's
to,
really a dumb question.
it's going to cause the fluid to infuse faster.
Okay.
So back in the day, us old nurses used to be up there squeezing the bag.
Trying to get to infuse faster.
Mhm,
Okay,
mhm.
gotcha.
And so now you new nurses, you'll just set the pump to $9.99.
It's when they're
I'm like,
Okay, I've never seen that in my life.
They have everything, they just choose ampicillin and already preset, but now you can just set it to $9.99 and that's gonna infuse it faster. But back in the day, and sometimes on your cardiac floors, you're gonna see these, okay? So at least now you know what it is. You
Yeah.
prime everything first, insert it, pump it up, because let's say we're limited on the number of IV pumps. This patient's critical, we're just going to go ahead and use our pressure.
Gotcha. Okay.
Alright, what other questions before you take your break? So when you come back, it's time to start priming. All right, 10-minute break. All right, restrooms are down the hall. I'll see y'all when you come back. Let me turn off this camera. About the rights of medication administration. Everyone give me one right. Right name, you're done. So right name, right patient, right time, you're two done.
Right route.
Right route,
Right order.
right order.
Medication.
Okay, right, what else? So let's talk about an order for Tylenol that is for a fever, and you decide to give it for a headache.
Right rationale.
Right indication. Sir, oh, sorry, ma'am. I don't know. Sorry, let me get your armband. All right, but my name is Eunice. I'm your nurse today. I'm here to start your IV because your doctor has ordered saline. It's going to help to improve your blood pressure or whatever. But let's say it was an antibiotic. I'm starting your antibiotic, and the patient says, "What's the name of the antibiotic?" And when you start giving information about that antibiotic, what is that called?
Education.
So, right patient, right drug, right time, right route, right indication, right education, right documentation. Like they keep going on and on and on. So the documentation is also important. What is the time frame on your medication? What's your window to give it?
30 minutes.
Depends. Most of the time it's not 30 minutes. What is it?
15 minutes.
No, an hour. Yeah, an hour. So like if it's say maybe something has a peak and trough, that is when you may have to do it within 30 minutes. But outside of that, you get like an hour to give your medications. But just making sure if it's a peak and trough that you're giving it right on time, that you're not waiting outside that hour time frame. If you do something outside the time frame, what is that? What have you done? It's a medical what? Error. Y'all pull these terms forth. Come on, it's a medical error. And we're going to prevent medical errors. Our patients do not have armbands. If this was your patient, they did not have armband, what would you have to do?
Look at something more.
Something else.
Ask them.
Okay, but you can't give medications without their armband in the hospital. Maybe in ALF it may be different, they won't have armbands. But so what else would you have to do if you're in the hospital?
Get one.
Should I go to him, go there and reprint?
You have to get one, okay? And so in your hospitals, they're going to have an armband. Patient identifiers, you're going to ask them what? Hey, is your name Mary Sue and is your date of birth 8888?
No.
So what should I say instead?
What's
What's your name and date of birth?
Okay, what's your name and date of birth? And so you have computers on wheels. So we are verifying this multiple ways. So when you have your MAR or your MAR that's on your computer, you have your medication. So now you verified the medication against the MAR. Now you're in your patient's room and you're verifying the patient, because normally you're scanning the patient and you're scanning their medication. What do you do if your system shuts down? Power outage or a system data breach, and you cannot use your electronic health records? You have to go back to paper. Sorry, you all, preparing you for these aliens. What is this? NS, it's normal saline. Gonna tear it, open it. Your secondary, we'll get to. You're going to spike and prime your primary. Take everything out of the package, I'm not gonna do it. I may have to do this one, sorry you all. I just wanna show you this. If while you're spiking and priming, you touch the spike, what do you have to do?
Get a new one.
Get a new one. You've contaminated it. You've contaminated those fluids. What is this vent for?
Bottles, glass
Bottles, albumin, nitroglycerin. And so if you have spiked and primed a bottle and you're trying to, what is this section called?
chamber.
The drip chamber. And you press on the drip chamber and everything's open and nothing's flowing, it's because you have to open this. And what is this called? Why am I big on you knowing your terms? Because I'm gonna stick this thing in that, and I'm gonna open up that thing, and then I'm gonna squeeze on this thing. So this is called a what? Spike. This is called a what?
Vent.
2 words.
Drip chamber.
How much of the drip chamber do you fill?
Halfway.
Half. Why? Because if you overfill it, you won't see what? The drips. What are these 3 things called? Your ports. Can a LPN do direct pushes?
No.
No. So I had my last class, there were LPNs who worked at a, I won't say what type of institution, but they were working at an institution. And they're usually the only ones there who are, medically licensed. And they said, well, I want to take your ACLS class. And I said, I don't recommend it. And they said, why not? Because I'm teaching you how to push emergency drugs that an LPN can't push. So even though you can take the ACLS class and you understand why to give Eprin, why to give the atropine, you can understand all of that, it's not within your scope of practice to give it. And so what should you do? You should follow your facility's protocols. And they may have to wait until the ambulance gets there. And those paramedics, the EMTs, they can sometimes, based on their levels, they can do the direct pushes. So don't do anything that's outside of your scope of practice. RN, how fast do you, in an emergency, how fast do you push a medication? Is it slow? Is it over 1 minute?
No, it's fast.
It's fast.
Yeah.
So in an emergency, cardiac arrest, I know what we taught you in nursing school. It was like, go slow. In an emergency, we're pushing fast. This is not an emergency. This is someone's morphine. How fast do you push it? Slow. Phenergan, if you have to give Phenergan, back when I started, we were giving Phenergan direct pushes. So if your patient needs Phenergan IV, you can do what so that it's not a direct push and you can still give it as an LPN? What could you do? If it's not a direct push, how could you infuse it? What would you put it in? How much? 1,000 ml bag? 100 ml bag, and then you can infuse it. Okay? That's what I said at Nurse Eunice's facility. You would have to contact your facility, but you all can do infusions. You cannot do direct pushes. I'm gonna put this back in here. What are these for?
To put on the ends of the, it's for infection.
And so once you remove one of those from your nurse port, do you have to go back and scrub the port? Everybody say yes.
Yes.
Pet peeve, nurses who don't like to clean. Pet peeve, nurses who don't like to listen. And you have those fancy stethoscopes. You are so proud of your stethoscope in nursing school. Look, I got the best stethoscope. And the 1,000 ml bag of normal saline. Now they're starting to have wet lung sounds that I can hear, okay? But let's say that I can't hear them, I just see their O2 sats dropping. That should prompt me to do what? Where do you listen? Show me with your hands.
All of the
Fields.
Okay, thank you. She finally went to the back. Yes. So it's not just, oh, I'm gonna listen here, I'm gonna listen here, because they could have coarse breath sounds in the basis. So I need for you to use your stethoscope. That's what it's there for. Because by the time they have pedal edema, is that early stage or late stage? Late stage. We could have caught it when it was early. Patient just came in, they're dehydrated. What we don't know is that they have CHF and their ejection fraction is 30. So we gave them all the fluid because we're trying to fix problem 1, and now we've caused problem 2. What happens after fluid, you all? Yeah, I gave her a whole liter of fluid. What happens now?
She's overloaded. No overload. She's hydrated.
Ma'am, do you need to pee? Do you need to pee? I'm not gonna say that word, but you know, so you need to be thinking of this. You're giving somebody IV fluid. If they can't walk to the bathroom, but they are ambulatory, what are you gonna put next to them? Bedside commode. Y'all have to teach your CNAs. So if y'all don't know it, polar old lady, hey, I just gave her a whole bunch of fluids. I need for you to make sure she goes to the bathroom within 2 hours. If she doesn't call, let me know so we can get her up. If a person has potassium in their bag, but they are not producing urine, what's going to happen? There should not be any K if there's no P. Why not?
Just build up and become. Gonna cause the potassium to build up. They're not excreting it.
Does everybody understand that? If your patient is not urinating, you should not be having them with a potassium infusion because it's going to become toxic. I think I'm done because I'm preaching now. As far as my alcohol swabs are concerned, whenever you are cleaning, and I haven't taught you how to start an IV, this is just I teach you in silos, so it's like nursing school. In nursing school, you were so ready to start an IV. We had to teach you gloving, asepsis. You gotta learn how to wash your hands. You gotta learn about your circulation system. And then your very last week, we're like, you can start IV now. So I'm teaching you backwards. We're teaching you IV fluids first. Now we'll teach you how to spike and prime. And then after that, usually after lunch, I will have the hands set up. And most of you all wear dark clothing. That is perfect. Our hands are bleeders. So you may, if there's a blood spill, I will take care of it. We try to use the mats. With your alcohol, just pretend. You don't have to really take the alcohol out. What size gloves do you ladies need?
I wear a small.
Small.
Mediums are okay.
Okay, I'll put mediums in the center. And so unfortunately, you may have to share over here. All right, so I need one person from each team up, one person from each team. Let's go to, what you're gonna do is, you're
Just
gonna.
go to one side.
Yes, so we have one on that side. So who's your teammate?
I don't care.
I don't have us three. Perfect, love it. So what you're gonna do is you're gonna start off with opening up your primary solution. Take it out of the bag. Enough? I do apologize, you all. I do apologize. Just start with gloves. Clean hands and gloves. So I see you sanitized. I saw you. And now glove up. And so if you need medium, there you on the table.
Both of us or just one person?
So you have a station near the wall and she has a station in the center. So you can put on gloves also. You have verified that you have the right patient, you have the right order. And everyone should have a trash can. So, and for right now with your bag, you can put it back on top of your bedside table because now you have to open up your primary tubing. With your primary tubing, once you take it out of its packaging, go ahead and start removing the little paper wrappers and clamp it. And so make sure you're keeping, don't just let that dangle, even though it still has a protective. You can hold it. Oh, yep, just hold it. And so you're going to be able to keep everything in your hands, unravel. Okay, clamp. Make sure it's clamped. Good. Okay, so not that one. So it's this one right here. So roll the wheel down and clamp it. Oh shoot, it's my son. Hey son, sorry. Hey, I got you on speakerphone.
Hi, son.
Yes, sir, what do you need?
I just wanted to tell you, doing my task.
You doing your task? Okay, all right. I'll call you when they go to lunch, okay? Thank you for getting up on time.
No problem.
All right, bye-bye. Love you. I'm son by a 13-year-old. It's like, you have work to do. You either gonna come here and go to work, or you got work to do at home. And so he chose to stay home and do his work, so. I mean, like, work for me. You know, you gotta do some work. You got a big old boy. I need you. You can do it, girl. You can do it. You can do it. Oh, Lord, you almost got it. Okay. So, and it's okay if it's not perfectly unraveled right now, because what's going to end up. So, and now, stop, pause. You're good. You got all that? You're right-handed or left-handed? Right-handed. All right, so you all now have all of that in one hand, because now I need you to pick up your bag with your other hand. Let's talk about these different ports. So this blue one is the one that you're going to remove, and then you're going to push your spike in, push and twist. If you don't do it straight, it's going to pierce the actual bag, and whenever you hang your bag, it's going to start. So you should literally see like the spike in this area. So the spike should like go in. What is the second port for? Medication. You have to check your facility to see what medication you can put in the bag. Some of them will allow you to put Phenergan, but this is what usually your pharmacist would be using if they have to add an additive. All right, so, and then if you contaminate the spike here, we move on. In the real world, throw everything away. All right, so pop the blue. I love that sound.
Yeah.
Good. Remove your protective cap off of your spike without contaminating your spike. You can do it, girl. There you go. You got it. Good. Push and twist. Push and twist. I'm so proud of y'all. Don't look at the camera. Do not look at the camera. Don't look at the camera. All right, and so now because you have everything clamped, you can hang it on your IV pole. Keep everything clamped. I'm so short. Sorry. All right, and so now unravel. Squeeze your, once everything's unraveled, squeeze your drip chamber to its half filled. Good. All right, so now remove the end cap off of the end of your tubing.
This here?
Yes, ma'am. And we're going to keep those because your partner's going to go behind you and do the same, so.
Right here.
Thank you. All right, and so now it's kind of like your Houdini. You have to like spread out your tubing so that it's going towards your trash can. Bam, okay. And now you have to slowly release your clamp. You have to open your clamp. And so this moves. So if you don't like this position on your clamp, everybody, you can move it down. So open up your clamp. And then watch as the air is removed from your line without allowing too much of the fluid to go on into the trash can. Make sure your line is clear there. Good job. Stop. It goes all your antibiotic. Okay. All right. So once your line is primed, you have two options. Remember that end has to remain sterile. So I'm over here with her. Clamp it, girl. Clamp it. Clamp it. Clamp it. There you. We're sorry. All right, so let me hold this. So your options are, you can either hold this in your hand, but if you're thinking that you're going to contaminate it, the back of your clamp has two prongs. Guess what those prongs are designed for? Bam. Go ahead and pretend clean your IV site. This IV is patent. What does patent mean?
It's open.
It's open. How do we know if it's open? What do we do to it first? We flushed it. I saw you all flush it. I saw you flush it. Scrub the hub according to the infusion, Nursing Infusion Society for how long?
30 seconds.
30 seconds.
It's right here. There it is, right there. Oh, okay, you can stop. Apologize.
Push in and twist. Push in and twist. Great job. Woo. But don't open, because you can connect, because you know our mannequins don't really have veins. Uh-oh. So guess what happened? You scrub the hub and then you let it touch the bed.
I gotta get a new one.
Stop mixing up alcohol, girl. Just pretend. So scrub, but then hold it so that you're not, letting it touch things. Good. There you go. Perfect. Push in. And now twist. This right here, no, that's the part you twist, the circular part right there. And now it's connected. That was part 1. Part 2. Remember that if you turn our 100 ml bags upside down, what's going to happen?
It's gonna spill.
So part 2 is, it's time for you to, now I'm gonna hold yours. So you go ahead, you get your secondary, everybody go ahead and open up your secondary tubing. And with your secondary tubing, I need you to hook your primary. So the first thing you're gonna get out from your secondary tubing is the hook. And you can put your tubing down, because, well, she's multitasking. She said, you didn't listen, Shay. Get the hook. Put that tubing back. Sorry. You all can do it. Good job over there. If you can double hook it, because it's not the best pole in the world. You got it, Shay. Yeah. I see you. Yeah. I can do it either way. Either way. No one's, it's like, not like a, okay.
I'm short and I wasn't wanting to.
It's okay, Shay, keep going. Your job right now is to not contaminate anything. So you see the, break it down. There you go, girl. Woo. Okay. Now, here's yours. Here's yours. I'll make sure that you have closed your clamp. I'm gonna teach you how to back prime. Secondary. But make sure you clamp off your secondary tubing. I'm gonna teach you how to back prime, because if we don't back prime, we're gonna end up wasting our secondary. Our antibiotics are gonna run into the trash. All right, so remove your spike, your golf tee. All right, but don't throw it away. I need those. Great. All right, now go ahead and spike. And great job, team. And if everyone's secondary tubing is clamped, you can now invert your bag and hang it on the IV pole. Just make sure it's clamped. It'll make sense in a moment. Don't squeeze, do not squeeze, don't squeeze, just hang it. Don't squeeze, just hang it. Don't squeeze anywhere you want.
Other side, there's things that it doesn't.
Yeah. Now, don't open up an alcohol swab for real. Get your alcohol swab, scrub the nurse port on your primary nearest the primary's drip chamber. Scrub, scrub, scrub. Then you're going to connect your secondary. You got it, Carol. I see you over there. All right. So now everybody pause. Once we have those connected. All right, so let's talk about back priming. What is the purpose of back priming?
To get fluid in your tubing and get the air out.
Yes, but we could have did that with regular priming. So why back prime? Because it prevents us from wasting our antibiotic. So that's why you don't have to squeeze on the drip chamber. If you squeeze on the drip chamber, you're probably going to overfill your drip chamber. But it's okay because you're overfilling your drip chamber with a compatible solution, such as normal saline. So what you do, and I'm not going to do it for her, all you're simply going to do is release your clamp. But whenever you are back priming, don't be so focused on watching it. I need you focused on looking at this chamber. Once the chamber is half filled, the only thing you have to do is raise it. And when you raise it, it's gonna stop back priming. If you lower this, it's gonna start filling again. So take your secondary off. Go ahead, it's okay, go ahead and open the clamp. Lower it and allow it to back prime.
No, it's not coming like that.
Let's see if it's starting to go now. Okay, now go ahead and watch it. It's gonna start.
That's pretty cool.
Oh, I see it.
Okay, once it's halfway, raise it. Great job. You got it, girl. Tippy toe. We're not done. What do we have to do with this new tubing?
Get the air out.
You got the air out. What do you have to do with this new tubing? Remember, documentation is part of the process, so how do you document that tubing is new? How do you document that is new tubing, so I don't throw it away? You have to label it, name, date, the time that you put it up there, and then, yeah, that's what you're gonna be doing. So before you leave your patient's room, you would make sure that you have opened your clamps, and you would have to, in most of your facilities, you have to connect this to an IV pump. We don't have an IV pump. So let's say we had to do this the old fashioned way. You literally be counting the drops as they drip. And that will, let's say you're supposed to have 16 drips per minute in order for that bag to be infused in 1 hour. You actually would have to sit there, count it, and time it. Let me see you take off your gloves first. Nope. Let me see you take off your gloves. Nope. Let me see you take off your gloves. Thank you. Hands lower than your elbows. Oh crap, let's keep on going. Don't touch your thumb to your gloves. Good, put it in the trash. So what were you ladies doing incorrectly? You touched your skin first, so it's going to be pinch and pull down first. Pinch and pull down first, and then contain, because that have blood on it. Contain, 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 and now 2 fingers under and off. And now trash. Did you touch the inside of that glove? I gotta watch you.
I don't know.
I gotta watch you. So why is the way that you remove your gloves important? Yeah, right now it's just water, but in a few days it's gonna be some C. diff, some blood, and everything else. Pretend you wash your hands, and you can actually use hand sanitizer. So now we have to reset our station. Sorry it took so long, but I know you all are gonna fly through this. Team members that went, if you see that your team member is needing assistance, please respectfully try to offer assistance. Not that everybody may want it. Me, help me, help me. All right, and so once you have your gloves, go ahead and clamp your primary tubing. It's okay, it's okay. We're so sorry. Our intentions were good. All right, so. And then if you can try to get everything straightened, but keep it in one hand, it would be good.
Are we pretending there's a cap?
Pretend there's a cap, pretend that's sterile. And then before you go any further, now you want to pick up your bag of saline. You're going to remove the spike that we keep. You all are doing something. Look how fast y'all are going. Boy, all right, remove your protective covering from your spike. Go ahead and spike your primary, push and twist, push and twist. And then if it's clamped, you can hold it right side up. And now you can hang it. What do you do next?
Prime it.
What do you squeeze on?
Drip chamber.
Good job. And once the drip chamber is half filled, what do you do now?
Unclamp it.
Unclamp it, but have your end towards the what?
Trash.
Trash or the sink. If you still have the cap on the end, it may not prime. So make sure you remove the cap off the end, but keep it clean. You all were great teachers. You all see this? Great job.
Look at that. Didn't do it. I feel like I made it harder than it actually was.
It's okay. It's
Well,
okay. Seeing
it's
it multiple
unfamiliar
times.
to us,
Yeah.
so once you
Seeing it multiple
doing it
times
more.
helps. All right, and if it doesn't flow, it's because it was well utilized. So if yours isn't flowing, it's okay. Just let me know, and I will come over and I will help it start flowing.
Yeah, mine's not
Okay,
going.
so whenever it does that, it's just because it's stubborn, and it just needs a good old nurse Eunice. There we go. Okay, it's okay, so what you'll do is you'll just squeeze the bag, and that'll make it flow. There you go. And you wouldn't have to do it in the real world, you're only doing that because we reused this set. So now you have to, once it's primed, make sure it's really primed. Once your tube is primed, you want to either hold that in your hand while you are cleaning the IV port, but if you don't wanna hold that, what could you attach it to? Yes. And then just make sure that when you lower it slowly so it doesn't hit anything. Perfect. I see you over there. Perfect. All right, so what you're cleaning with the alcohol is not your IV, what your IV fluid. What you're cleaning instead is the port. So you can actually release that. You can let it, there you go. Lower it down, yep, don't let it touch anything. So like you see hers? Oh crap. You didn't
Because
hold it
mine's
on.
really
Hole, if you have it connected to that piece.
So like, so you can, if you think that's gonna touch. Sorry about that, dear. Sorry, it touched my hand, it was supposed to touch my hand. All I did was just hang it up there. My apologies.
That's what I did too.
Okay.
We can be-
Let me just go. Yes,
Good
please.
job, Julia.
Whoop, whoop. You got a whole cheerleader over here.
We went to the whole nurses school together.
Aw.
So we're each other's biggest supporters.
And so, Julia, slow down, girl, slow down. I'm still waiting for her to start to connect her IV fluid over there.
Can tell we're already doing this at work.
Good job, good job. Now you all can get the hook from your secondary bag of fluid, and so you can lay it on the bag if you think it's gonna touch, on the bed if you think it's gonna touch the floor. So get your hook and hook your primary. Okay, Joe, you can just ask. Good job, everybody. You're flying through this. And now you can spike and prime your secondary. Oh, let me get your secondary. That would help. Make sure your secondary tubing is already clamped. It'll make your life easier because you're just gonna simply back prime. Once you spike it,
This is also piggybacking.
yeah, that's piggybacking, yes. Good job. Do not squeeze on the drip chamber. You're just going to hang it. Clean your nurse port. Nearest the drip chamber of the primary. Clean the nurse port nearest the drip chamber on the primary. And once that's cleaned, you can connect your secondary. Is it going?
No.
Okay, so you know we had to do last time was.
It's just because of the green.
But you
scrub.
want that back kind of, so you gotta lower it. You don't want to make that.
Oh, no, yes.
Yeah, take this one off.
Now, am I unclamping this one or no?
Lower this, just this
Oh,
one,
yeah.
yes, and then.
In the real world, you
Not
don't
too
clamp.
high.
Okay.
But for this one, I'll unclamp this one and it should back prime.
See, cause you wanna get all the air out, so lower this one. And then,
Until all bubbles
until
come
all
off.
the, yeah, this would come back this way.
And so again, if you overfill when you're back priming, it just means that it's gonna take longer for that antibiotic to infuse. And so try to keep your drip chamber how? All the way filled?
No,
Half filled.
If it's,
Oh no, don't turn it up, it doesn't, just instead of it infusing over an hour, it may have to infuse over an hour and 10 minutes. So that'll be the difference. But if you had it on a pump and you overfilled it when you back prime, that means that you'd have to change the volume on the pump. Because if you overfilled it, it's no longer 100 mLs in that bag, it's now 110. Why is that important? Because if you go back into the room 2 hours later and there's still antibiotic left, you're like, they didn't get all their medicine. So In the real world, you would leave with all of your clamps unclamped. Never leave until you look back and see what happening. It's dripping. It's dripping. What questions do you have? No questions?
No question.
Juliet's a mannequin. Clamp it, girl. Don't do my mannequin like that. Now let's talk about these different ports. And I think the easiest is Carla. Can I trade places with you and I'll come over there? All right. So I need one thing up. Pretend there is no antibiotic infusing, because if there is antibiotic infusing, if antibiotic had infused through this tubing at all, I should not be doing any direct pushes because it could still have some of the antibiotic, which means we would have an incompatibility. So there's no antibiotic, this is just normal saline. Nurses can do direct pushes. Something else we can use this for is for air bubbles. So take my medication, which I've drawn up. I'm going to scrub my hub. I'm going to push and connect my syringe. But now if I push, there's going to be resistance because I'm pushing in medicine, but it's dispersing in both directions. So in order to force it to go into the patient, I would have to kink it. And then I would push slowly, I would give my medicine. Can an LPN do this? No, but an RN can, and some of you are gonna be RN soon. What else could I do? Pretend this was an empty syringe. And my IV pump kept saying above stream occlusion. So with your IV pump, there's usually one port that's sticking out above the IV pump. I would open up the IV pump, have my syringe with nothing in it, clean my hub, connect it, and do what? Pull back. I would have to pinch this though, otherwise I'd be pulling the patient's blood in. But when I pull back, if there's an air bubble or something in there, I'd be able to remove the air bubble. You can do the same at either of these ports. If there's an air bubble, you can remove it. What's the benefit of using a syringe method to remove an air bubble versus disconnecting this?
It's more controlled.
More control and something else.
Less risk of infection.
Less risk of infection. Every time I disconnect this and reconnect it, I could be introducing bacteria. What questions do you have about that? All right, you've done such a great job. Let me disconnect this. Doom, 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 doom. Hands are clean. I got gloves on. I'm gonna disconnect this because you know what? You get to go for a walk. You don't get medicine again for a long time. So you're gonna go for a walk, okay? They have end caps that are green for these two. I don't like this way down here. So what am I going to do, everybody? I'm gonna move it. I'm gonna clamp this green one. Unclamp this one, move it up to where I want it at. Clean, 10 seconds, 20 seconds, 30 seconds, wherever your facility policy is. And just push this saline fast. Is that what I'm gonna do?
No.
So I'm gonna push it slow. What am I asking the patient? Hey, I'm flushing your IV. Tell me if you feel any pain. What am I also looking for?
Swelling.
Swelling. That could tell me if it's oh my God.
Infiltrated.
Infiltrated. That word is not coming to my mind today. And so now that I'm flushing, it's kind of hard to see. There's a clamp here. And so we call this positive pressure. You're literally pressing on the plunger as you clamp. What's the purpose of positive pressure?
So you can get a backflow of blood.
Girl, give me an air high five.
Yeah.
Because what is it? What would a backflow of blood do internally to that catheter?
Clotted.
Clotted. Girl, you're good. You can go for your walk now. It's time for your smoke break. Ladies, let me see you take off your gloves. Nope. Thank you, Carla. Thank you. We started off well.
Different challenge.
Good job, everybody. So what questions do you have about this process?
Can you come with me to work and teach me?
Girl, you can do just come back from lunch early. You know how to do this whole thing. You got this. You can practice again.
Check it out behind her head of what 100,000
We have a goal one now.
Yeah.
Oh, you do. So crazy.
Look it up on YouTube.
I started reading to people. Like during the pandemic, I saw that my babies couldn't read, and I just started reading to people. I was like, oh wow, a lot of people need to be read to. That's literally what I do all night. I read to people. So, any questions about this part? Back priming. Priming's, yes.
So the green clamps?
Yes. Go ahead and take one off. Go ahead and take one off. Oh, sorry. I thought some of the other green clamps. Okay, go ahead and clamp it.
How would you?
Just push it.
Just push it.
You got it. Push it towards the narrow. Uh-oh. I'm happy, y'all. Thank y'all for helping her. Thank you.
Zoom in here, you come from this side. It's good.
Her facial expression.
Oh, okay. I was like, how?
So let's
Okay,
talk
so you
about
move it.
why do you think they have so many clamps?
So like just in case we want.
In case something fails.
Yeah.
In case something fails. But if something fails, how can you clamp it manually? Folded. So if something's going on with my patient, like when I'm teaching phlebotomy, sometimes the butterfly disconnects. And so if it disconnects from the vacutainer, blood's coming. I need that blood. So what I'm gonna do instead is I'm gonna pinch it and I'm gonna reconnect it. And if that wasn't a culture, I'm good to go. If it was a culture,
You gotta start it again.
you gotta start all over again. So if something goes wrong in the medical world and something's moving and you don't want it to move, what are you gonna do to it?
Clamp it.
Clamp it. All right. Next question. Good. Any questions? All right. You all can go write some notes and then I'll see you all in 30 minutes. Great job.